1991. She's an EB member since 2003, which is quite highly commendable. She's also in charge of ICU and Pediatric Neurology Epilepsy Department, and she has been a member of COVID task force during the COVID pandemic. Welcome, ma'am. Our next chairperson is Dr. Sandeep Kaude. Dr. Sandeep Kaude is a famous pediatrician and an adolescent health expert from Bhosri, Pune area. He's a director of Vatsalya Child Care, Mother and Child Care Center, Bhosri. We welcome you, sir. I remember the days when we had to wait for days to get the ECG done. And one day, stars fell down and we caught an electrocardiogram in our hospital. Even an abdominal surgery would never be done unless 4 to 5 bottles of blood were made available and ready. Then came a day when we cut open an organ full of blood without spilling a drop on a table. Such strides of medicine have today enabled us to perform surgeries on hearts a size as small as strawberry. Dr. Rao sir, who's a very famous pediatric cardiac surgeon from Kokilaben Dhirubhai Ambani Hospital, will be here to guide us, enlighten us more about the recent advances in pediatric. Also, there is we are lucky to have Dr. Mohanty to accompany him to more enlighten about the recent advances in pediatrics. We welcome you, sir, for your first talk on the recent advances of pediatric surgery.
Good morning to all of you, my chairpersons and my colleagues and friends. I know it's a difficult thing on such a lovely morning to come and listen to a boring talk in a MAHAPEDICON conference, but then the show has to go on, and we should get going. With your permission, I've made a slight change in my talk to give you a much more perspective of what is pediatric and congenital heart surgery today in our country. The first half of my talk will be to highlight the advances made over the last 4 decades of this branch, and also to let you know, introspect and forecast perhaps what are the problems we'll be facing in the future, and make some provocative observations on the basis of the current experience. The next part, Dr. Mohanty will be recounting some of our experience at Kokilaben Hospital for your information. He's my senior colleague at the same unit. So over the last 40 years, pediatric cardiac surgery has witnessed an explosive growth in India. Perhaps you have found few specialties witnessing this growth. More centers, more infrastructure, numbers, complexity, better outcomes have been delivered. And today we have more than 100 centers doing these surgeries with 25 dedicated units. If you see the history over the decades, 1980 to 1990 truly was the birth of pediatric cardiac surgery in India. And 2 fountainheads of this surgery, one in Chennai, where I was trained, and in Delhi, the All India Institute of Medical Sciences, they have thrown up this specialty for the country. So there were thoughts of this becoming a subspecialty. The surgeon was in charge of all aspects of care, with supportive specialties like anesthesia, cardiology, intensive care, all evolving in the period. Perfusion was in its infancy, but echocardiography began emerging as a very important diagnostic tool for diagnosis of congenital heart disease. The surgery was not all that great, with mortalities in the region of 20 to 25%, and neonates obviously had no hope then. The next decade was a decade of explosive growth and tremendous excitement. I'm truly fortunate to be present during this period, because this is the period when we started the Amrita Institute of Medical Sciences program in Cochin, for which I'm truly honored and privileged to be part of it. When pediatric cardiac surgery began recognized as a separate specialty of cardiovascular thoracic surgery, and a lot of other specialties supportive to the surgeon, that's cardiologists, anesthesiologists, intensivists, and all these other specialties started to evolve. Echocardiography was perfected, and the great advance was the availability of prostaglandins E1 for treatment of neonates with duct-dependent circulation. So that truly changed the whole spectrum of surgery. And this was the decade which we also started to attempt neonatal surgeries, not very successful all the while, but still, I think initial successes were seen in simpler cases. In the 20 years after 2000, this was, I would term, the neonatal decade, and perhaps the zenith of pediatric cardiac surgery, which we're witnessing today. There is sophistication in diagnosis. Very sophisticated imaging techniques are commonly available. Lot of skill sets in all the ancillary specialties have developed. Pediatric perfusion has come of age, and we are able to operate either successfully, very successfully, or even palliate a host of neonatal conditions. Extracorporeal life support, the thresholds have come down now, and we're able to support children on ECMO, on other forms of support for periods of time till cardiac recovery. And importantly, corporates also started started showing interest in this specialty and gave a tremendous push for this, for the establishment of these programs. And of late, we are finding advances in financial schemes available for BPL families, which is a very, very good thing. And we are taking baby steps to include congenital heart surgeries and diseases in the insurance coverage program of the country. So obviously, this has translated into reduction of infant mortality rate, whatever percentage it is. And I think with all our efforts and your efforts in Maharashtra, we are now in third place after Kerala and Tamil Nadu in terms of infant mortality rates of the country. So that is a tremendous advance in a huge state like Maharashtra. This specialty has thrown up what teamwork can do. What you are seeing here is our team at Kokiraben Dhirubhai Ambani Hospital for the care of the cardiac child. And I'm truly proud of what we have achieved in this team over the last 13 years of our existence. And this is one field where if the team and the cogs in the team are not good, you don't get good outcomes. The other area which has truly witnessed tremendous progression is neonatal cardiopulmonary perfusion. In the days gone by, this is the picture of the child we used to see, edematous, and usually all the efforts would end in a tragedy. There were innumerable problems and lot of problems, and in the ICU, in the theater, and we would lose the child. But today, confidently, we can operate on a 1.4 kilo, 1 week premature child successfully. And this one of our recent cases who is being discharged perhaps today from an open heart surgery. These are some of the other cases which we have tackled over the last decades. Dr. Mohanty will give you a few examples in his talk. And the one in the center is perhaps the youngest age, which we have done at 17 hours of age when we have corrected the transposition in this neonate. The next few slides will show some of the long-term issues in these children, long-term effects of the surgery on these children. This is one of our children who was operated 3 months of age, a complex double-aortic right ventricle with pulmonary stenosis, 8-year post-op, and she's a good Bharatanatyam dancer in a school. This is one of the cases I operated in Cochin when I was there. This child was flown from Mumbai, who was 1.75 kilos at birth. And today he's a civil engineer graduate student in Navi Mumbai, graduating very shortly. This another child of transposition, 12 days of age, underwent an emergency arterial switch, a budding doctor in Calicut. Another child, tetralogy, operated 1 year of age. He is an engineering student in Bangalore. This is one of our young girl children, operated at 20 days of age, underwent an arterial switch, reoperated 6 months later for stenosis of the right coronary artery. And today she is a 12-year-old young lady she is indeed a cradle of talent. This child is a special one to me because we operated on the day tsunami hit Chennai in 2004 at 5 days of age. And today he is a 18-year-old child who is a school swimming champion. Tricuspid atresia with pulmonary stenosis. Another child who underwent 3 surgeries, 2 months BT shunt when I was in Chennai. He followed me to Amrita in Glen when we did a Glen, completed his Fontaine in Kokilaben. He finished his engineering, finished his master's in US, and now he is a happy husband, which is pretty rare. So where do we go from here? The common adage is what goes up has to come down sometime. So the next part of my talk will be on what are the problems we're encountering in pediatric cardiac surgery today. So one of the biggest lows of pediatric cardiac surgery has been neonatal and sick child transport. We must be having at least mortality of half a dozen or more children getting transferred from various parts of Maharashtra to a center, dying on the way. So this is one place I think all our efforts should be directed to make neonatal transport much safer, because air transport, though existent, is beyond the affordability of our parents. So I'd like to quote from this paper of Indian Pediatrics in 2008. This group looked at long-distance neonatal transport, the need of the hour, and as they rightly surmise and conclude that unless the neonate is stabilized, you will not have a successful transport to a higher referral center. When I was looking at this table, of the same paper, one of the things which caught my eye was the fact that the ones which are highlighted in red font, hyaline membrane disease, pulmonary hypertension, meconium aspiration, and others, obstructed TAPVCs have not been mentioned. I think in today's practice, it is very, very high on the cards when you are having any of these diagnoses, because this is one thing which we can treat and perhaps even cure the child. The other low point, I think, is this talk of free surgeries. It does sound very good, but we all know that there is no free lunch. Everything has a cost to be paid. And for a resource-intensive specialty like pediatric cardiac surgery, this is anathema. Because what is happening now, we are beginning to see more and more in our practices. A child's heart surgery is deemed to be done free by right by the parents. I feel this is undervaluing ourselves and the care, because no one is aware of the true cost of care. This leads to poor remuneration, does not retain talent. We cannot give the full spectrum and quality of care. There are many instances in institutes where there are a selection of cases cutting corners, cutting down on complexities, and this will lead to poorer outcomes. If you see the Indian scene, this is a good paper which was published by Dr. Krishna Kumar in Annals of Pediatric Cardiology, and draw a line from Chennai to Kanpur. You can see how very badly the centers have been distributed in this country, the skewed distribution. It's all towards the west and the south of the country, and the east and northeast is hardly any center. So barely 50% of all the figures which need to be done are being currently. So we need more centers and more staff. I'm sure all of you will have read these headlines in the papers not very long ago that super specialty seats are going vacant, and they have removed the constraints of merit for super specialty seats. 174 cardiothoracic seats last year, 134 went vacant across the country. So this is an emerging problem, which I'm sure all of you has to be conscious about, because 10 years down the line, you will not have pediatric cardiac surgeons at this rate. I also find that in our junior colleagues now, there is slackening interest in taking up pediatric cardiac surgery because of inadequate remuneration for the work. And in a private hospital, they always are with a stigma of a loss-making unit in a private hospital, so they won't get the perks. There's a long training period, long hours of work, unfavorable work-life balance, and they had to depend on a team. But there are better alternative specialties, so very few people are coming in for this branch. The fourth problem has been nursing. Bad nursing is directly proportional to the outcomes seen in pediatric cardiac surgery. So today, more than 50% of our nurses leave the country. Those who are trained just leave. Poor working conditions and salaries are not letting them take up pediatric nursing. So if you ask me the question, is pediatric cardiac care in trouble? I would say an emphatic yes. So unless we have a universal healthcare insurance cover, which should be done as a sort of a priority, unless we recognize that for the younger generation, remuneration proportionate to the skill and hours of work they put in for medical and nursing staff, this only will attract new talent. We have to cease to equate it to a mission, but see it as a highly skilled specialty that has a cost to be paid for delivering excellence. We have to get out of this mindset that free is holy and any fees paid for or charged is a swindle. By doing this, we are undermining or undervaluing our specialty, skills, and I believe we'll be shooting ourselves in the foot in the long term. I hope I'm proved wrong in the future. Thank you very much.
Thank you so much, sir. I request Dr. Mohanty, sir, to give his presentation.
Very good morning to all. As you heard a very lucid presentation by Dr. Rao about the realities of pediatric cardiac surgery, I will be over next 10 minutes taking you through my thought process. So I've titled my talk as A Stitch in Time, Real Patient, Real Stories. So all of you know that when the baby is born, three things happens. The patent foramen oval that closes, the ductus arteriosus closes, and ductus venosus closes. So based upon this closing of the duct, the congenital heart defects are reclassified. For survival, if you need the duct patency for pulmonary flow, then it is seen in, I'm sorry, how do, excuse me. Yeah, sorry, fine. So for the ductal patency to continue the pulmonary flow, we have the spectrum of critical PS, pulmonary atresia, interventricular septum, tricuspid atresia, and tetralogy of Fallot. For maintenance systemic flow, you have congenital aortic stenosis, coarctation, interrupted aortic arch, and hypoplastic left heart syndrome. And where the duct is required for mixing, it is transposition. And there are few ductal independence lesions which also present in the neonatal period, that obstructed TAPVC, truncus, alcapa, and very large left to right shunt like large ASD, large VSD, and PDA. So based upon this, the common congenital heart defect that you would be seeing is all picturized in this particular slide, which you will come across in your day-to-day practice. I'll take you through the referral paradigm in our unit has been, if we pick up a heart defect in the fetal stage, then it is referred to a pediatric cardiologist, and we take it out from there for the surgery. Then after the baby is born, in many situations, all of you suspect a cardiac defect based upon the symptomatology, and then you refer it to pediatric cardiology, then they land up getting operated. Or whenever there is a acute emergency in terms of either shock or severe cyanosis, then they are also picked up and taken to a referral center for pediatric cardiology diagnosis and surgery. So you see the few cases that we have recently operated in last month itself. So it's a 2.1 kg, 24-day male patient from Aurangabad. He came to our facility with very feeble pulses, increased CRT. There was a clear-cut difference between the right upper limb and lower limb blood pressures, and there was hardly a very soft systolic murmur over the pericardium. Now this baby, when we took the X-ray, it was just like this massive cardiomegaly with increased pulmonary flow, and the echo revealed the whole diagnosis of a hypoplastic left heart variant, where the baby had a hypoplastic mitral valve, borderline LV, borderline aortic valve, hypoplastic arch with severe coarctation, very large ASD, and a very large LSVC to the dilated coronary sinus, causing almost inflow obstruction, while the interventricular septum was intact. So we imaged this baby further with a CT scan, where the arch hypoplasia was confirmed. The branching pattern was very different and difficult, with a aberrant right subclavian artery almost arising from the pre-coarcted segment. Now this baby was taken up for surgery. We did an arch repair with a pericardial patch augmentation. We closed the ASD with a fenestration. The coronary sinus was unroofed and re-endothelized. The left SVC was rerouted to the right atrium. And finally, this is one picture of the surgery, the LSVC being rerouted to the right atrium. And this child, the chest was kept open for 2 days and closed on the 3rd postoperative day. He was extubated on the 4th postoperative day. Currently, he is in our ICU with OG fits, and maybe in next 1 week, he will be discharged from the hospital. So this is possible in a 2.1 kg baby with a hypoplastic left heart syndrome. Now, case 2 is a 10-day-old neonate brought to our emergency department. Again, this child was already discharged. They went home. He was 2 kg at birth. And on the day 3, the baby became tachycardic with poor peripheral pulses, with severe cyanosis ranging from 25 to 30%. And as usual, there was no murmur. Chest was clear. There was no hepatomegaly. So when he came to us, this was the X-ray and ECG. ECG was sinus rhythm with right axis deviation. Echocardiography was done, and immediately the diagnosis of transposition of great arteries with intact ventricular septum, small ASD with bidirectional shunt, and small PDA was established. So this child was stabilized with a prostaglandin drip. We put him on ventilator with a FiO2 of 20%. He was saturating around 80 to 85% on ventilator. and severe metabolic acidosis was seen in the AVG. That was corrected after screening the septic parameters, and this child was taken up for an emergency arterial switch operation. So as you know, this surgery demands, it's a 7 to 8 hour surgery, which demands perfect precision, because the neonatal coronary arteries have to be transported to the new site, and they are just like ball pen refill size coronary arteries. So this child got extubated and was discharged on the POD 8. So case 3, a 3.4 kg 29-day-old female, referred from this city only, Nasik. This child had a corrected transposition of great arteries, VSD, pulmonary stenosis or atresia. So we did a CT scan to see that the branch pulmonary arteries were not confluent and it was feeding through a very small duct. So after establishing the diagnosis, what we did is we unifocalized the right and left pulmonary artery, we augmented the confluence, and we put a BT shunt from the aorta to the pulmonary artery confluence. And this is the post-operative CT done to demonstrate see the flow of the right, BT shunt, and the pulmonary arteries are now fine. So as Dr. Rao showed in one of his slides, that if you see this particular whiteout X-ray as a practicing neonatologist or pediatrician, the common thing that will come to your mind that it's a whiteout X-ray, and most likely if the baby is premature, it must be hyaline membrane disease. If he is not premature, then you have a host of diagnosis like ARDS, hyaline membrane disease, meconium aspiration, septic shock, medicinal tumor. It can be just effusion, it can be global pneumonia, airway obstruction. But nobody really seriously thinks about obstructed TAPVC. So what I want to emphasize and request all of you that please examine the child and think what your mind knows only your eyes can see. Look for the femoral pulses, look for the oxygenation saturation probe is now commonly available after the COVID at least, and please do auscultate for murmurs. If there is a murmur, it is actually in fact a less severe disease. If there is no murmur, like a hypoplast or a TAPVC or an interrupted arch, it is a more severe disease. So just want to tell you that day in and day out, we are operating on kids as small as 1.4. The open heart, the smallest baby we have operated is 560 gram PDA, who is now grown up to almost 6 years. And this requires a teamwork. Just to show you, this is our OR. And we get the babies. This is how the oxygenator and the heart-lung machine looks. This is how the ICU looks. And this is possible only because of a huge teamwork, and where there is really participation of everyone, and you are the first cog in the wheel who starts the process of recognizing the disease and then referring them to us. So as a surgeon, I can expect that you people will do the first runner in the relay in saving this child and making him productive in life. Thank you so much for your attention.
Sir, please be on the stage for the felicitation.
Thank you, sir, for highlighting all these about this is a literally real change we are getting. And see, it was before 32 years when we were postgraduate and when we started practice. It was the thing ki congenital heart disease or any surgery except VSD. Leave it. There he is going to die. But now word has changed. But definitely there is a need of all these things, all those points Dr. Suresh told us, that insurance and everything. I think we should now insist on insurance. Our team like IFE, definitely we are trying for insurance so that it will be easy and that mortality we can reduce again and again. Thank you, sir.
Thank you. May I request Dr. Suresh Rao, sir, to be on the stage for the felicitation? I'll request Dr. Sushma Save ma'am to felicitate Dr. Suresh Rao. I'll request Dr. Vasant Haratkar to felicitate Dr. Mohanty. May I call upon our eminent speaker, Dr. Shantanu Singh, who is an experienced consultant for over nearly 20 years now. Sir is a pediatric hematologist, oncologist, and an expert in the stem cell transplant. As you all know, that bone marrow transplant replaces unhealthy marrow with a healthy one. BMT is not a surgery. It's like giving blood or medicine through an IV, and from there the cells find their way into your marrow. It can take months or years to recover from the BMT. But bone marrow transplants are complex treatments that carry the significant risk of the serious complications. It's important that we are aware of both the risks and the possible benefits before the treatment begins. And so the question arises, can we, should we? So let's go get the answers from our expert, Dr. Shantanu Sir. Sir, the stage is yours.
Thank you so much for calling me to this beautiful city. I mean, it's one of my favorite cities. We have a clinic here, and every time I come to Nashik, I really feel very happy, especially during the monsoons, best time to be here. So my specialty, stem cell transplant. So if we start, we have to say what are stem cells? So put it in very basic, stem cells basically are undifferentiated cells that has a capacity not only to differentiate, they can actually differentiate and multiply in various types of organs. And that we can actually find them at various places. You can find them in the blood. You can get some stem cells in the heart. But the ones that we are most interested in is what we call as embryonic or pluripotent stem cells. So a pluripotent stem cell has the capacity to differentiate into many, many other organs. So you have a pluripotent stem cell that can at a certain point differentiate into intestinal cells, can become liver cells, cardiac cells, nerve cells. But when we talk about stem cell transplant, we really talk about what we say is hematopoietic stem cell transplant, or these are the stem cells that makes up our blood cells. So these would be, if I use the pointer on my, so this is the stem cell rather, which will differentiate into either the lymphoid or the myeloid progenitor. And then basically from that, we will be getting our plasma cells, our T cells, B cells, NK cells, our RBCs, platelets. And this is where our specialty is all about. If we look at from where we get the stem cells, we have three basic sources. We have one, the umbilical cord, from where we can take umbilical cord stem cells. We can collect them from the marrow or the bone marrow. And now where we use more often is we take peripheral blood stem cells or mobilized peripheral blood stem cells. And there are some differences between these three, because the umbilical cord stem cells are the most primitive. And these are very good for us to use because they're so premature. When we do a transplant with umbilical cord stem cells, you don't get the problem, too much of a problem with graft versus host disease. So if we are doing a transplant where we do not want GVHD, say for a thalassemia or a sickle cell, then an umbilical cord would be a very good source. The second, a slightly more mature, would be what we use very often, which is bone marrow, because in our country right now, we don't have too much umbilical cord stem cell banks. And again, bone marrow is excellent for the same purpose if you do thal. But then sometimes you would like to have a little more mature stem cells because you want to harness the power of graft versus host disease to cure your patient of a leukemia. And in these cases, using a little more mature mobilized peripheral blood stem cells would be very good. The other types of stem cells that are there, which are the induced pluripotent stem cells or the stem cells from fetus, they really don't have a clinical established use as of the moment, but we can look towards the future and we know at a certain point we would be able to use them to repair various organs, and that's an exciting field. But I'm going to limit myself to our talk today, which is BMT, bone marrow transplant, but it's better described as a stem cell transplant because that's what we were talking about, that it's all about stem cells that we do, or more specifically, it's a hematopoietic stem cell transplant. We have a couple of two types of transplants that we do. We have autologous stem cell transplants where we take the patient's own hematopoietic stem cells to treat him. And then there's allogenic, where we need the stem cells from a donor. And even in that, we can look at whether we are taking the allogenic stem cells from a fully matched family donor, which means that they're absolutely genetically identical within the family. Usually it's a sibling, a brother or sister. Very, very rarely in close communities, we might find a match in a parent as well. The second is where you have to do a matched unrelated. So this is where we look out at various stem cell registries to try and see if they have a match there. And finally, and this is a very exciting field, that nowadays we can do transplants even when your donor is only 50% matched. And this is called a half matched or a haploidentical donor. So I described the two different types of transplant, the autologous and allogenic, and I'll just kind of talk a couple of seconds as to how the transplant happens. So when we look at an autologous transplant where we take the stem cells from the patient themselves, what we would do is we would mobilize the stem cells from the bone marrow to the bloodstream using chemotherapy. Then we will put the patient on an apheresis machine, which will collect the blood and separate out the stem cells, which will then be frozen and kept in our deep freezer. After that, we would use mega doses of chemotherapy to wipe out the cancer for which the transplant is being done. And usually it can be a neuroblastoma or a multiple myeloma. And after the cancer has been wiped out by our chemo, the stem cells are returned back as a drip. And sometimes many patients kind of feel it's like almost a anticlimax. They've been building up to a transplant, and all it is a blood transfusion. And to be honest, that's what it is. And then the body gradually recovers over a period of 3 to 6 months, sometimes a little bit longer, but usually with a autologous transplant, we're able to discharge the patient within about 21 days. And fingers crossed, if you're doing it properly, this shouldn't have too much of a problem. As I said, that this is very useful when the aim of a transplant is to deliver mega doses of chemotherapy or radiotherapy to eradicate a cancer that is not in the bone marrow. And that's very important, because if you have a cancer in the bone marrow and you collect the marrow, you'll be giving the cancer back to the patient. So this is useful when you're treating a lymphoma, a lymph gland cancer, neuroblastoma, which is basically in the abdomen, chest, multiple myelomas, and some other solid tumors like Wilms, bone tumors. We can use autologous transplant. The other area where an autologous BMT can be extremely useful is for neurological conditions like relapsing remitting multiple sclerosis, where the patient is getting recurrent symptoms. Doing an autologous transplant can be the difference between a patient who's coming into the hospital and one who gets completely cured. If we go to the next type of transplant, which is allogenic, this is where we would need to collect the stem cells from a donor. Same way we would give chemotherapy to kind of increase the stem cells. And after that, we would process and freeze the stem cells. At the same time as the stem cells are being frozen, we would be giving chemotherapy to our patient and then reinfuse the donor cells back to the patient. Much more complicated, longer stay, lots more immunosuppression needed. But one thing that's very good in our specialty is that when we do a stem cell transplant, in almost all cases, we are able to stop all our immunosuppression within 6 months to a year. So if we do a thalassemia transplant, we have to continue immunosuppression slightly longer, up to a year. Leukemia transplants, we stop within 6 months. So after a successful transplant, unlike a solid organ transplant like a liver or even cardiac transplant, where a patient needs to remain immunosuppressed lifelong, our patients can be medication-free within a year. So this is useful for cancers that has involved the bone marrow, because you can't use the same marrow. And it's also very useful when we want to give them a completely new cell line, which is dysfunctional, which would be very useful for aplastic anemia, severe combined immunodeficiency, thalassemia, sickle cell disease. How does it work? It works by eradicating disease involving the bone marrow by chemoradiotherapy, and then we replace either the patient's or own, and then wait for recovery. And this we talked about already. So If we talk about transplant, we talk about, do we really need to? And this is data from the US, and it talks about how many transplants has been done over the last few decades. And if you look at it, our specialty started sometime in 1980. And at the moment, when we are in 2021, the US does close to 24,000 transplants every year. I just put up this little cartoon to show how our specialty has developed over the last few decades. So as I said, our whole specialty started in 80s to 90s. And in the first decade, we are taking our baby steps towards transplant. And the ones that were happening was the matched related donor. So this would be the fully matched transplants that were happening. Outcomes were not that great, but we were just at the start of our specialty. By the time we hit 90s to 2000s, and that's when I got into my specialty, we saw an explosion of unrelated donor transplants taking place. But at the same time, the other thing that started developing is this red line, which is the cord blood transplants that was starting to take up. The next decade saw an explosion of unrelated donor transplants going up. So whereas the matched sibling donor transplants still were happening, there was an explosion of unrelated donor. This was when all the stem cell registries were set up across the world, and we were able to kind of find matched donors who were not in the family and do it. Cord transplants also were slowly and gradually increasing. And as we come to this decade, we find that unrelated donor transplants have become the kind of largest group of BMTs that we do. Matched siblings had taken a little bit of a downward trend because families have contracted. We no longer have large families. It's more difficult to find a match within the family. The other thing is the cord cells have taken a dip down because we are not doing too many cords, because this is new type of transplant called a haplotransplant, where we are able to do a transplant within the family from a donor who can be only half matched and have a good outcome. India also, we've seen number of transplants skyrocketing. We have about 2,500 transplants happening every year, which can be for myeloma, AML, and we talked about this. And these are the Indian data to show what transplants are happening here. We have about close to 110 transplant centers in India as we speak, and hopefully many more will come up. But is it enough? Well, not really. If you look at the USA data, as for the population and the number of transplants they do, 1 in 15,000 needs a transplant there, and that's what they get. Whereas in India, we only are able to do 1 in 500,000. So many more patients who need it are not being able to do it. One part of my talk, major part, is indications, and I'll go through this quickly, which is, and we have some various papers and guidelines which tells us which ones, which diseases which should be transplanted. And we have our Indian guidelines as well now, which are based on these ASCT and EBMT guidelines. And I'll just take you through this. It's very simple. So if you remember this little diagram, which talks about hematopoietic stem cells, and think what goes wrong. So if the actual primitive stem cell is something wrong with it, which happens in aplastic anemia, we can do it. If there's something wrong with the erythroblast, pure red cell aplasia, with the erythrocytes itself, hemoglobinopathies, platelet series, amegakaryocytic anemia, platelets would be Glanzmann's. And if you go across to the lymphoid progenitor cells, CGD with neutrophils and monocytes with osteopetrosis, all of these diseases we can treat. Going across to the lymphoid progenitor, if you have a SCID, which is a defect there, that can be treated. Or going down the T cell and the B cell, the immunodeficiencies can be treated with this. And then the mucopolysaccharidosis and Gaucher. So that is our indication. But I had a couple of cases, but I just want to take you straight away because I've got a little less time to a little bit of work that we've been doing in our own center. So this is the cases where we talked about malignant diseases, neuroblastomas, leukemias, lymphomas, non-malignant, aplastic, thalassemia, sickle cell disease. And this is important because when we say what we can treat, we have to say what we still can't treat as of today. We really cannot treat Duchenne's muscular or other neurological diseases like cerebral palsy, autism, spinal injuries. Because as I said, what we deal with and what is actually indicated is hematopoietic stem cells. these stem cells will not be able to generate any kind of neurological tissue. Say for Duchenne's, you need to produce dystrophin. Dystrophin is not produced by the hematopoietic stem cell line. So doing a stem cell transplant, a hematopoietic stem cell transplant for Duchenne's is actually absolutely useless. And there are regulations which say how you can do it and what research that can be done, but that's for something else. Over the last few days to years, we've done a lot of HLA typing camps across the country with partnership with Patut. And these are all the areas we've been traveled to do HLA typing to make it more accessible and available free of cost for our patients. That's the various camps we've been traveling. Very recently went to Patna and we held one of the country's largest camps where we had 350 patients where we did their HLA typing test to find a donor for the THAL patients. But finding a donor is not enough because then the transplant has to be done. And this is where we had a very good tie-up with Coal India, where they have this Thalassemia Bal Seva Yojana. And under this, the government actually helps to provide 10 lakh of rupees for the transplant. And under this, we've been able to make a change in many lives over the last few days. I'll end quietly with that little small cartoon to say that if you have to keep pace with cancer, we need to reinvent ourselves and go on. I hope I've been able to give you some idea of what transplants we do, and thank you so much.
Thank you so much, sir, for so much enlightenment about the bone marrow transplant. When I was in Australia in 2008, the head of the department there said that it is a crime to not do a bone marrow transplant in a thalassemia kids. And in India, because of the financial constraint, we still can't do it. I mean, all the children I've seen with iron overload, they are still moving around with all the complications. But I'm hoping with Shantanu Sen sir around, we will have that day that none of the thalassemia kid will die of iron overload. I will request Dr. Kaude sir to felicitate Dr. Shantanu Sen. Sushma ma'am, you wanted to ask some questions?
Yeah, thank you, Shantanu, for that lucid talk. And I think it's an awareness which is very important for the hematopoietic stem cell transplantation. And as a pediatrician, I think if you see a thalassemia and sickle, at least we should refer them as early as possible for hematopoietic stem cell transplantation. So that is the take-home message I think everybody who's present here should take. Yeah, thank you so much.
Thank you so much, sir. Thank you. Sitting in our clinics and attending to our patients with cough, cold, fever does not mean that we only have to shove the torch down the throat of the mouth of babies. Putting on the stethoscope on his chest to complete our ritual. A good pediatrician could see the child walking into his clinic and after finishing his respiratory examination, could take the attention of parents to the child's stance, gait, etc. to pick up any aberrations the parents may not have noticed either too. But several parents who may not have noticed their child having flat foot, intern foot, or gait disorder or a limp. We have termed this as office orthopedics because we first see it in our office and then we send it to our friendly neighborhood to orthopedic office. To enlighten more about office orthopedics, we have Dr. Vikas Basa, who specializes in pediatric orthopedic, who will tell more about these issues. I request Dr. Vikas Basa to kindly come to the stage and enlighten us about office orthopedics. Thank you, sir.
Thank you, madam, for that wonderful introduction. I thank organizers also for inviting me for this lecture to enlighten you on my topic. So I'm a consultant pediatric orthopedic surgeon from Kokila Bendiruba Ambani Hospital. So today I'll be talking on common orthopedic conditions which you may be coming across in your day-to-day practice and wanted to deal with the parents before you refer them to a pediatric orthopedic surgeon. So I hope this talk will definitely help you in your practice. So pediatric orthopedics is an interesting subspecialty which deals with orthopedic conditions in children right from birth up to 18 years of age. I really privileged to take up this specialty because unlike other subspecialties of the orthopedics, it's a subject which deals with growth and development of a child. So I say that we don't treat the children right from the birth. The pediatric orthopedic starts right from the womb. Because as the fetus is growing, so many aberrations can happen and a child can deliver with a congenital anomaly. So definitely there is a need for a pediatric orthopedic surgeon because you need a thorough knowledge about the growth and development of the child. For that, you need a specialized training to deal with the problems. And you need to have a unique approach to deal with the parents as well. And for that, you need a skill and experience. So I want to ask you that from the audience, how many of you think that looking at this child, looking at this picture, you think that this child has rickets? Is a 1 year, 2 years, so 1 year, 2 months old child already started walking, but he has this bowing in the legs. So is this a ricket? So many of you, when you see a child in your clinic, may be having a doubt. So let me tell you, already this child is being referred to me by a pediatrician after giving an adequate dose of vitamin D, thinking that it's a ricket. But is it? So when this child was referred to me, when I saw him walking, what I found was he has a lateral thrust. So what I mean by having lateral thrust? So during the mid stance of the gait cycle, the knee is pushing laterally. The knee goes buckled. So when he walks like this. The knee is pushed laterally. So that is called a lateral thrust. So if you see carefully, the bowing is mainly in the tibia. There's an abrupt bow in the proximal tibia. And he has a inward in-toeing or the inward type of walking when he's walking. So when you have these many conditions and if it is not getting resolved by vitamin D therapy, definitely you should think beyond rickets. So when I saw the X-ray of this child, so he has an abrupt slope of the metaphysis here. There's a sharp angulation of the epiphysis and there's a beaking of the proximal medial metaphysis. So obviously the X-ray doesn't show any signs of vitamin D deficiency. So what it is? Yes, correct. So this is a case of Blount's, which was described way back in 1937 by Dr. Walter Blount. So what the Blount is? It's an osteochondrosis of the proximal medial tibial epiphysis causing progressive varus deformity. So what we do for this, it's very simple. So brace these children whenever they are standing and walking. So the deformity gets eventually corrected as the child grows. So what is the normal evolution of the lower limbs in children? So to begin with, they're born with a genu varum. And from during the infancy, they'll have a genu varum. And up to 1 year, so 2 years, the limbs become straight. And from 2 to 2 years, they have a physiological genu valgum. And from 4 years onwards, they gradually become straightened out at the age of 7 years. So this is when they have adult type of walking pattern. And their foot size is also almost reaching to the adult size. So unless you know the normal evolution of the this lower limbs, I'm ruling out that they do not have vitamin D deficiency. So this is absolutely normal. This is what the normal pattern of the lower limb alignment in children. if anything which is persisting beyond this age group has to be evaluated thoroughly. So let me tell you, at least one patient in a day I see in my clinic of these flat feet. So parents are very excited when the children start to walk, but the moment they look at their feet, they're a little upset. They say that the child has a flat foot. So they usually brought with this kind of feet to me. So I don't say this as a flat foot. I say this as a fat foot, because the foot is full of fat and less of muscles. The muscles are yet to develop. So the moment you make the child standing on the toes, you can see the arch appearing there. So the arch starts to develop only after the age of 3 years. Initially, the foot is full of fat. As the fat decreases and the muscle starts to develop, from the age of 3 onwards, they gradually develop these arches. So if any child is brought to me below 3 years of age saying that it is a flat foot, I just turn my deaf ear to them. I just simply counsel the parents, and then I say that please do come after 3 years if the appearance is still the same. But when I look at this kind of feet, I'm a little concerned. So because here, the child not only having a severe flat foot, but if you see the heel is pointing out and the child is literally walking on the medial border of the foot. So this is not normal. So this is called pes planus valgus deformity. This definitely needs a treatment. So what we do for this is we give them a supramalleolar orthosis. This is a kind of brace which fits into foot and ankle, and it stabilizes both the foot and ankle and gradually corrects the deformity. So we ask the children or the parents to wear these kind of braces whenever the child is standing and walking. Most of the times they come back saying that, the foot is the same. When I ask, are you really using these braces? Yes, whenever the child is sleeping, we are putting on. No, that is absolutely wrong. So this brace works only when the child is weight bearing in this orthosis or the brace. So they should wear this brace at least 6 to 8 hours in a day to see the change of the arch coming back. I think most of the times, even in your clinics, you may be dealing with the kids who are walking with the in-toeing type of gait. The foot is turned inward. They walk with the in-toeing. So the parents are a little worried. So what maybe the problem could be? So the problem may be in the foot, that is the metatarsus adductus, the foot turns completely inward. That's the reason why they're walking in the in-toeing of gait. Or there may be problem in the leg, which is called tibial intorsion. Or they may be having an excessive femoral anteversion. The femur is turned inward. So whenever I deal with such kind of cases, the very first question I ask to the parents is your child sitting in this position most of the time? If the answer is yes, 50% of the problem is solved there. So if you avoid sitting in W position, usually the in-toeing type of gait is resolved over the period of time. So to begin with, when they're born, they have an excessive femoral anteversion. But if they continue to sit in W position beyond 1 year or 2 years of age, then they tend to have increased femoral anteversion and they walk with the in-toeing. So the bone profile changes because of persistent sitting in W position. So the moment you avoid making them sit in W position, gradually up to 8 years, this in-toeing type of walking is resolved. You don't need any special kind of treatment. So sometimes if the children, they don't listen, we ask them to go for a physiotherapy, but usually nothing works. Spontaneously, it resolves by itself. So this is a 6-year-old child who is intelligent, came with the progressive deformities of both the legs. So if you look at both the legs, there is a windswept deformity. One side he has a genu valgum and the other side he has a genu varum. As if a wind blowing from one side, pushing both the knees to the opposite end. So, but if you carefully see, his trunk is larger than as compared to the limbs. So he has a relative macrocephaly, there is a rhizomalia, and he has a brachydactyly and pectus excavatum. So almost all features of vitamin D deficiency are also seen here. But when you see a dysmorphic features in such kind of children having short stature, you should think beyond rickets. So we do a skeletal survey in these kind of children. We take the X-ray lateral view of the skull, X-ray of the whole spine, AP lateral, and the standing scanograms. So when you look at the epiphysis is not normal. It's very dysplastic. Even the metaphysis is also involved in this child. There's a widening and cupping of the metaphysis, and he has a beaking of the vertebral bodies there. So there is an involvement of the spine, involvement of the epiphysis and the metaphysis. So we label this as a spondyloepimetaphyseal dysplasia. So he has even the family history. If you look at the father is also having a short stature and similar kind of deformities in the limbs. So how do we differentiate between the skeletal dysplasia and rickets? So on your right side, there's a similar age of the child who has rickets, the X-ray of the hands, and on the other side we have the patient X-rays. So if you see the metaphysis is cupped, but the epiphysis is dysplastic, but whereas in rickets the epiphysis is absolutely normal. And our child has a dysplastic carpal bones. The carpal bones are not well developed, but whereas in the rickets the carpal bones are well developed. And if you see the phalanges, they're short, chubby, and very broad, as if giving an appearance like a bullet. So this is how we differentiate between the dysplasia and the vitamin D deficiency, that's the rickets. So what they need, obviously, is not able to walk because of the windswept deformity. So what we do is a growth epiphysiodesis, putting such kind of a small 8 plates to correct the deformity. Within 3 months, the limbs are straight now. So you may be coming across children who are very active in sports and they complain of pain in the legs, ankles, elbows. So this we term as overuse syndromes. The spectrum of these ankle sprain, Sever's disease, Osgood-Schlatter, these are all called overuse syndromes. So how do we deal with this? Usually they need rest, but it's very difficult to restrain from playing. So you hydrate them well and give a kind of a good physiotherapy and good warm-up exercises before the play can take care of these overuse syndromes. Transient synovitis of the hip, which is very common below the age of 5 years. You may be coming across a child without any trauma, maybe start to limp, and the parents do not have any clue why the child is limping. So any trivial trauma or bacterial viral infections can trigger this transient synovitis of the hip. So the best modality to diagnose this is an ultrasound. So if you see, that's unaffected hip, where the fat planes are very adherent to the bone, but whereas there is a hypoechoic shadow, elevation, and the collection, this black is a collection of the fluid in the femoral, at the area of femoral neck. So once you see this, you diagnose that this is a transient synovitis of the hip. Then what is the treatment? Of course, rest, but it's very difficult. But what I say is at least restrict their activities. If you cannot put them on the bed for a complete bed rest, but at least restrict their activities. And simple ibuprofen or paracetamol NSAIDs, or when they are sleeping, keeping the hips in wide abduction will definitely help in treating this transient synovitis. And let me tell you, it is a very self-limiting condition. It doesn't usually requires any treatment. Within 1 week, usually it resolves by itself. So the most common fracture what you may be seeing when the child falls on the outstretched hand is the supracollar humerus fracture. It's a very common fracture in pediatric orthopedics. So the moment I see this kind of fracture with this sharp angulation of the proximal humerus sticking out there, I'm literally worried about the radial artery because there's a high chance of brachial artery injury. So whenever you see a child who fell on an outstretched hand, you suspect a supracollar humerus fracture, please do palpate the radial artery. If there is no radial artery palpation, well palpable, then you should think of vascular injury and you should refer them as early as possible. So we reduce the fracture and fix them with the K wires in this fashion. Usually children, they don't require any fancy implants. Once you align the fracture and immobilize them for 3 to 4 weeks, they usually heal well. Pulled elbow, I think, definitely, yeah. So I think definitely you may be seeing a lot of pulled elbows. During the pandemic, through video consultations, I taught many pediatricians how to reduce the pulled elbows. So what happens is when the child is pulled with the hand abruptly, so the annular ligament of the proximal radioulnar joint, it slips into the joint and it avoids or restricts the elbow movements.
I'm afraid to interrupt you, sir, but time is up. So
Okay.
2 more minutes and then.
Yeah, sure. I think then we can stop here. We can take the questions if required. Yeah. Thank you so much.
Thank you very much, sir. A very brief but very in-depth review of cases we see in OPD. So any questions for us, sir? Pulled elbow management.
Acha, you want to continue the management of the pulled elbow? Okay. So I'm glad you have an interest in learning about reducing the pulled elbow. Yeah. So most of the times what happens is when the child is playing. Acha, okay. Yeah. When the child is playing and sitting on the ground, we have the habit of pulling them with the hand abruptly. So because these children are very flexible, so this annular ligament goes and slips into the joint and it restricts the movements. So usually they present with elbow in extension and forearm in pronation. They just don't move, but they are happy. They're not crying all the time unless you are handling that hand. So what you have to do is slowly, gently taking them into confidence, gently flex the elbow. And as you're flexing the elbow, supinate the forearm. So when you do this maneuver, you feel or you hear a click sound. So that means the annular ligament is coming back and sitting in its place. So that's how you reduce the pulled elbow. But that's not where it ends. Educating the parents is very important to avoid this condition. So children should not be pulled by the hand. Children should not be swung with their hands to the wrist. So there is a high chance of having pulled elbows. And we at Kokilaben Hospital, we have a unique approach of screening the high-risk babies. So especially any NICU graduate who's premature, below 30 weeks, and having history of neonatal sepsis, or a breech presentation, especially a firstborn female child to an elderly primary, has a high risk of having hip dislocations. So we go in and we check the hips for Ottolani and Barlow test, and we make sure that the hips are very stable. So these high-risk babies are seen by a team of doctors, pediatricians, including me, neurologists, neurologists, developmental pediatricians, and the physiotherapist. And there are a lot of myths. Maybe, most of the times you may be asked this question. Can I use, okay. So I think we can stop. This is the last slide. So only the take home message is no walkers are recommended. And is the massage allowed? Yes, but be very gentle because we've seen neonates having fractures because of the vigorous and forceful massage. Thank you.
Thank you so much, sir. Definitely pulled elbow. I think I'll be feeling little bit confident to touch that elbow. It was a very insightful lecture. Because of the constraint of time, we couldn't continue. Extremely sorry. Nashik IP will invite you once again, sir.
I love to come back.
Yes, thank you, sir. I'll request Dr. Vasant Khalatkar, sir, to felicitate Dr. Basa, sir. That finishes our first 3 lectures of our first day of conference, of first half of our day. We'll felicitate our chairperson for giving their valuable time coming all the way from Nagpur, Pune and Bombay. Thanks a lot for your time and we are really privileged for you to be here and gracing this MAHAPEDICON. I'll first request Dr. Nitin Surana sir to kindly felicitate Dr. Save madam. Thank you, ma'am. I'll also request Nitin Surana sir only to felicitate Dr. Kavade sir. Thank you, Dr. Kavade sir. I'll request Dr. Surana sir to felicitate Dr. Vasant Khalatkar sir. Thank you, sir. Our next session is a plenary session. Antibiotics, think before you ink. It's already started in Panchavati Hall. The relay will be going over here. If the Panchavati Hall is full, all can come back to this hall. It will be relayed on the projector here. Thank you.
हा माईक बंद कर ना.